Cerebral palsy describes a group of permanent disorders of the development of movement and posture causing activity limitation that are attributed to non-progressive disturbances that occurred in the developing fetal or infant brain. The motor disorders of cerebral palsy are often accompanied by disturbances of sensation, perception, cognition, communication, and behaviour, by epilepsy, and by secondary musculoskeletal problems. Individuals with cerebral palsy have difficulty in controlling their movements and exercising. The purpose of this presentation is to outline the pathophysiology, etiology, pathogenesis, and clinical course of the condition. The presentation will also highlight the effects the condition has on movement control and the treatments and interventions. Finally, the presentation will discuss the research literature as it relates to the benefits of exercise and guidelines for exercise prescription. Cerebral palsy can be broken down into three categories: spastic diplegia, spastic hemiplegia, or spastic quadriplegia. Spastic diplegia is when the sufferer has tightness in both hips and legs and has difficulty walking. Spastic hemiplegia is when one hemisphere is affected and the symptoms appear on the opposite side of the body. Spastic quadriplegia is the most severe form of cerebral palsy and affects all four limbs, the trunk, and can even affect the autonomic nervous system. Pathophysiology is the physiology of disorder. Physiology is a branch of biology that describes processes or mechanisms that operate within an organism. Jenkins and Spear proposed that 4 criteria are prerequisites if one is to propose that an intrapartum hypoxic ischemic insult has caused a moderate to severe neonatal encephalopathy that subsequently results in cerebral palsy. Importantly, all 4 criteria must be met. 1. Evidence of metabolic acidosis in fetal umbilical cord arterial blood obtained at delivery with a pH of less than 7 and a base deficit of 12 millimoles per litre or more. 2. Early onset of severe or moderate neonatal encephalopathy in infants more than 34 or 4 weeks gestation. 3. Cerebral palsy of the spastic, quadriplegic or dyskinetic type. And 4. Exclusion of other identifiable etiologies such as trauma, coagulation, disorders, infectious conditions, or genetic disorders. Hankins and Spear state that these 4 mechanisms are the processes that are affected and form the physiology of disordered function. Cerebral palsy is a group of disorders. Due to this fact, the etiology or cause of cerebral palsy is multifactorial. An international consensus statement by McLennan in 1999 provided the following possible causes: developmental abnormalities, metabolic abnormalities, autoimmune and coagulation disorders, infections, trauma, and hypoxia. Recent research strongly suggests that the large majority of neurological pathologies causing cerebral palsy occur as a result of multifactorial and mostly unpreventable reasons during either fetal development or the neonatal period. Pathogenesis refers to the physiological processes involved in disease development. Because cerebral palsy is a non-progressive disturbance that occurs at the fetal or infant brain, the disease is developed in utero or in the birthing process. Cerebral and Horvath state that brain abnormalities such as maldevelopment or lesions in the sense of defects characterize different timing periods of compromise in the developing fetus. The same authors inform us that periventricular white matter lesions were the most frequent at 56%, followed by cortical and deep grey matter lesions, 18%. Brain maldevelopments were rather rare at 9%. Cerebral and Horvath state that cerebral palsy originates from an interference, lesion, or abnormality of the developing brain. From the research by Cerebral and Horvath, we can assume that cerebral palsy usually manifests in the fetal brain, and the defects that occur depend on the timing and the development of the fetal brain. Cerebral palsy originates in the developing brain of a fetus or can be caused by ataxia and trauma during childbirth. Russman, Tilton, and Gorman Jr. state that the symptoms of cerebral palsy are made up by 4 categories. 1. Loss of selective motor control. 2. Abnormal muscle tone. 3. Imbalance between muscle agonists and antagonists. 4. Impaired balance. Diagnosis can be difficult as signs and symptoms can sometimes remain unnoticed until the motor deficit is evident. Ashwell, Russman, Blasco-Miller, Sandler, Sherrill and Stevenson tell us the diagnosis of cerebral palsy always involves a motor deficit, and the usual presenting complaint for which medical evaluation is sought is that the child is not reaching motor milestones at the appropriate chronological age. Cerebral palsy is non-progressive, meaning the symptoms do not get any worse with age or development. Krieger provides a list of symptoms from varying ranges of cerebral palsy, mild, moderate, and severe, and the effect they can have on movement and exercise. Abnormal neurologic control refers to a lack of selective muscle control. This could indicate issues in the premotor area of the posterior section of the frontal lobe. Abnormal sensation and perception, touch and pain are affected. This could be indicative of issues in the primary sensory cortex. Hearing and vision abnormalities. 25 to 39% of adults have visual defects. 18% have hearing problems. These problems may indicate issues in the occipital lobe and the right parietal lobe. Impaired oral motor functions can cause temporomandibular joint contractures, vomiting, reflux, poor nutrition, and communication difficulties. This may indicate issues with the spinal cord, in particular the trigeminal cranial nerve. Markedly reduced bone mass. This can lead to osteopenia, osteoporosis, fractures, and scoliosis. Spasticity and contractures. This prevents the stretching or relaxing of muscles, which in turn causes them to grow and then develop into bones. It can cause difficulty with gross and fine motor skills. Pain results from hip dislocations, repetitive use syndromes, and degenerative joint disease. Treatments and interventions for cerebral palsy include surgery, gait analysis, administered substances, aquatic training, and resistance training. Surgery, such as pelvic and femoral osteotomy, which refers to a shortening of bones, and posterior rhizotomy, which involves surgical severing of specific nerves that are causing tightness through spasticity. Gait analysis can be useful as a treatment through practice and as a comparative measure pre- and post-operatively. Administered substances, such as medications and even Botox, have been found to be beneficial. Aquatic training can be beneficial as the water offers light resistance and buoyancy to alleviate joint stress. Resistance training must be progressive and closely supervised in order to be most effective. Research has looked at varying forms of exercise in relation to cerebral palsy sufferers. Some forms are virtual reality muscle engagement, compared virtual reality to conventional home exercise, and found that children enjoyed the virtual reality more and achieved a greater range of motion. Aquatic exercise. Kelly and Dara investigated the effect of aquatic exercise on children with cerebral palsy and compared it to the effects of land-based exercise. They found a lack of evidence for aquatic training over land-based training, with the exception being children with significant movement limitations. They also suggested the two forms of training be used in conjunction. Strength training offers cerebral palsy sufferers the opportunity to increase strength in muscles vital to walking, such as the hamstrings and quadriceps, without increasing spasticity. Benefits to gait function can be achieved through strength training. Lee, Saul, and Hugh found that after completing a strength training program, cerebral palsy sufferers demonstrated significant increases in strength and gait speed, as well as stride length. Guidelines for the strength training program can be taken from Fagenborg, who states that a very specific training program is required to increase muscle strength. The training intensity needs to be progressive, meaning the load is increased over time as muscles become stronger, and the program should be made up of 1 to 3 sets of each exercise. Within each set, muscle fatigue is reached between 8 to 12 repetitions, and exercise sessions are performed at least twice per week. Exercises can be isolation or compound movements depending depending on the desired outcome, both have been found to be effective. Functional movements have been investigated to a lesser extent with promising results. Cerebral palsy is a multifaceted condition with a range of causes and a spectrum of severity. This range means that different classifications of sufferers can respond differently to treatments and interventions. Surgical and medical interventions have proven to be effective in the past, with the current movement toward exercise-based treatments. Investigations into aquatic exercise and virtual reality movement indicated there could be ways to increase the enjoyment of the training for cerebral palsy sufferers. Research indicates strength training can have a positive effect on most cerebral palsy sufferers, with evidence suggesting that it does not increase spasticity among sufferers, even when performed at high intensities.